So there's been a number of people that have asked me to do lectures on TB, and I think I did a comprehensive video, if I'm not mistaken, on the channel. But I thought that video did not do justice to the topic because there's quite a lot that you need to discuss when it comes to TB. So I've decided to actually divide this lecture on TB into different parts and videos that I'm going to display to you at the end of this lecture, the things that you should look out for. So today I wanted us to talk about TB management in adults. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon so you never miss on such amazing content every time I post. Happy New Year, because this is the very first video that I'm posting of the year, and hope we reach 30,000 subscribers. And by the end of the year, I hope we should reach 60,000 subscribers on this particular channel. So I'm just going to jump right in because I'm not going to waste time looking at the TB basics, looking at investigations and all that, because we're going to cover that in another video. So remember that every patient that is found with TB must be started on treatment immediately, because you're aiming to cure this patient, you're aiming to reduce the risk of infection of others, you're aiming to prevent progression and complications of the TB, you're preventing relapse, and you're also preventing the development of acquired resistance. So it's very important that all patients that are found with TB are actually started on the right medication, and they're taking the medication at the right time, they're taking the right combination of drugs, and this is important because it's going to be ensuring that there is effectiveness of therapy. Remember that we don't treat TB with one drug, we use multiple drugs. So we must use these multiple drugs for effective treatment, and there is no rule of adding a single drug to a failing regimen. For example, you do your sputum test in the last month of your TB therapy course, or at month number 5, and you find that this patient has smear positive TB at month number 5, then you would say that this patient has treatment failure. You wouldn't add a single drug to the regimen that is already failing. There is no rule for monotherapy. Like I told you, we use multiple drugs, and this should be taken specifically for a specific period of time, and this is going to be depending on the severity of the disease and generally the expert clinical opinion, the opinion of you as a clinician. There's a few classifications that I want you to remember. One of them is based on the treatment history. So you have your patients that are what we consider new TB patients. These are your patients that have bacteriologically confirmed or clinically diagnosed TB and have not been treated for TB, or they have been on TB treatment for less than 1 month. We call those as new TB cases. Then the relapse is those that were on TB treatment and they had taken the TB treatment and they were declared cured, or have recently completed the course that they took recently, and then after that they are found with TB. They either may be a new relapse or maybe it's a new episode of a reinfection. Then you have those that have treatment after failure, so that someone who was previously treated for TB and their most recently completed course resulted in a treatment failure. Then you have those that have treatment after loss to follow-up. So these are the patients that were previously treated for TB and they were declared loss to follow-up at the end of their previous TB treatment course. Then you have others, those that don't have anything that is documented, or the recent outcome of their previous treatment is not really known. So for purposes of this class, we're going to be largely focusing on drug-sensitive TB. We will do another video on drug-resistant TB, because I feel that's something that is rather underrated and not really properly taught, especially in school. So when you talk about treatment of TB, you have two main forms. You have what is known as the non-severe form, and you have what is known as the severe form. The non-severe forms are those that are either bacteriologically confirmed, meaning that you have done tests for TB, the gold standard, of course, being either in your setup, for example, your culture, and you have realized that, okay, you have grown TB from that, or you can do your gene expert with your test for rifampicin resistance. But if your gene expert comes out positive, or your culture comes out positive, your smear comes out positive, then that's what we refer to as bacteriologically confirmed TB. Or you can have those that have clinically diagnosed TB. They have the signs and symptoms of TB, but these results came out negative, but there's still a high index of suspicion that this patient may have TB, and it may even show some suggestive features on some investigations like an X-ray. It could also be some other extrapulmonary forms of TB like TB adenitis, TB abdomen, and cutaneous TB. Miliary TB, on the other hand, is considered as a non-severe form of TB only if it does not involve the meninges. If you have miliary TB and it involves the meninges, then we consider that as severe form of TB. But otherwise, miliary TB considered as non-severe form of TB. And also, if someone has miliary TB, we consider it as pulmonary TB because the problem is actually within the lungs. The initial lesion is within the lungs. Then for severe forms of TB, I want you to remember 4. TB meningitis, osteoarticular TB, ocular TB, and spinal TB. The reason why these are actually considered as severe forms of TB is because, number one, it's very difficult to assess for response to treatment in some of these types of TB, like, for example, osteoarticular TB, ocular TB, very difficult to assess the response to treatment, which is why often the treatment duration is actually a bit longer. Then for other things, it's also you also want to prevent severity of the disease and possible complications, for example, those that have develop tuberculosis, those that have TB meningitis. So the drug-sensitive, the non-severe forms of TB, we treat them for 6 months. All types of TB, we treat them for 6 months. Way back, you would get different regimens, but now I think it has been made a bit easier. So it's either 6 months or 12 months. For the severe forms of TB, you're going to be treating them for 12 months. But as we'll see, there's a newer regimen that has been introduced, and I think in pediatrics, a 4-month regimen that we'll discuss when we look at TB management in children. So the total duration for the severe forms, like I said, it reduces the risk of disability and mortality, for example, in those people that have TB meningitis and tuberculosis. Then it also is important for those that have difficulty in assessing the response to treatment. For example, those that have osteoarticular TB, spinal, or even ocular type of TB. And remember that often patients that come in with TB are often malnourished or undernourished, so they need some sort of nutrient supplementation. They need some micronutrient supplementation with things like vitamin D, zinc, thiamine, B complex, and some other multivitamins, depending on your clinical evaluation, especially if it's a patient that was a chronic alcoholic. And you want to encourage all your patients to consume a healthy diet and to consume indigenous food and fruits. So there are some things that you want to do before you start your patient on treatment. You want to provide adherence counseling. This must be done before the patient starts treatment. It must be done during treatment at every visit, because you want this to be quite important, because for them taking their drugs, it reduces the risk of them transmitting the infection to other people in the community. It reduces the risk of resistance. It reduces the risk of progression. And of course, it enables them to be cured of the TB, because remember that TB is a curable disease. So you also want to discuss with the family members about the TB and the treatment of TB, because these are the people that are going to be supporting your patients, and they're going to be helping the patients become more adherent. So the counseling must not only be for the patient, but also for the caregivers at home. You want to do some nutritional counseling, do a nutritional assessment. So make sure that you involve the nutritionalists as much as possible. You want to calculate your BMI at the beginning, and that should be the minimal thing that you should do according to your nutritional assessment. And you must weigh your patients each and every visit that you come, because you want to modify your drugs based on the weight of the patient. You want to explain the patient's responsibility in their treatment. They have that responsibility to be taking the medication and to be looking out for certain side effects. And you as a healthcare worker, you also have responsibilities to the patient in the treatment of their TB. There are some baseline treatments or baseline tests that you want to do, a full blood count, because of course there are some side effects like thrombocytopenia with some of the drugs, as we shall see. Renal function test, remember that drugs like pyrazinamide get excreted by the kidneys. Liver function tests, for obvious reasons, TB drugs are hepatotoxic, and some of them are metabolized and excreted by the biliary system. So you want to get liver function tests for these. But remember that these tests should not delay you being able to start treatment. So the first-line drugs that are going to be used in treating drugs susceptible TB, you can remember the mnemonic RIPE. So R for rifampicin, H for isoniazid, Z for pyrazinamide, E for ethambutol. So we'll begin with rifampicin. It's a bactericidal drug, so it kills the mycobacterium. It has quite a high potency. How does it work? It's going to be inhibiting a certain enzyme that's known as DNA-dependent RNA polymerase. So it in essence, inhibits transcription. This is one of the drugs that is considered as the backbone for TB treatment, which is why it's quite important to check for its resistance. Even when we're doing a gene expert, we often check for resistance to rifampicin. It's the most effective at sterilizing the mycobacterium, and it makes short course durations quite possible. It has some side effects, and when it comes to the side effects, we largely divide them into three groups. You have the minor side effects. Often patients do not actually even require to stop the medication. You just reassure them, you give them some symptomatic management, and then of course they continue on the TB treatment. Then you have those that are major side effects that may actually warrant the patient to stop the TB medication. Then you monitor them, and then when you can restart it, you can restart the TB medication. There's a way in which you restart the TB medication that I'll talk about, especially for those that develop hepatic injury. Then you have the life-threatening type of side effects where they want to stop the TB medication. So the major side effects for rifampicin, it of course causes hepatitis. It's an inducer of P50. So cytochrome P450 rather. So remember that this here is very important. Why is this very important? Because number one, there are some drugs that are metabolized by this particular enzyme. There are some drugs that depend on this particular enzyme. For this reason, rifampicin has some drug-to-drug interaction with some of the drugs, as you will notice that rifampicin actually lowers the effective concentration of hormones, hormonal contraceptives in the bloodstream. So it means that when someone is having TB and they want to have some form of contraception, they would use barrier methods like condoms as opposed to hormonal contraceptives. It can also cause acute renal failure, shock, purpura, severe skin rash with mucosal involvement. That's your Stevens-Johnson syndrome, though it's not so common. It can cause thrombocytopenia. Then minor side effects are things like anorexia, nausea, abdominal pain, itching, orange or pink or red discoloration of the tears, sweat, and the urine. This is one common one that can worry the patient because they'll think that they have blood in the urine, but you just simply have to reassure the patient that it's due to a side effect of the medication. Then you have isoniazid, which inhibits mycolic acid. Remember that this is part of the cell wall, so it's a cell wall synthesis inhibitor. It's also a bactericidal drug, and it has high potency. It kills more than 90% of the TB bacilli in a few days. So remember that rifampicin and isoniazid are actually the backbone of TB treatment, which is why they are given throughout the entire course of TB treatment, which is why when you have resistance to these two types of drugs, you have to change your regimen and use a different strategy. Then you have major side effects like jaundice, hepatitis. It's also hepatotoxic. It's age dependent and has some severe skin rash like Stevens-Johnson syndrome, psychosis, and convulsions. Minor side effects are things like itching, burning sensation in the feet, which could be part of a peripheral neuropathy. This one here is very important because there are some patients that come in. For example, those patients that may have relapse or reinfections, they'll come in and they'll totally refuse to take these TB medications because they have nasty side effects. I once saw a patient when I was doing my clinical rotations, back when I was a medical student. I saw a patient that had nasty effects of peripheral neuropathy. They literally refused to take the medication when they were found with TB again. Why does this happen? Remember that isoniazid will inhibit a certain enzyme that's known as pyridoxine phosphokinase, and this enzyme is what is quite important in converting pyridoxine, which is vitamin B6, into an activated form, that's pyridoxal 5' phosphate. So once this doesn't happen, then the levels of vitamin B6 in the body reduce, they develop peripheral neuropathy, which is why preemptively we give patients vitamin B6 when they're on TB treatment to prevent this. Isoniazid can also cause sideroblastic anemia. Pyrazinamide, we don't really know, we're not so sure about the mechanism of action. There are many different mechanisms that have been postulated. There is no one that's universally accepted worldwide. It's a bactericidal, but it has a low potency. It takes about 2 to 3 months for it to achieve its sterilizing effect. You have some major side effects like severe skin reactions. That's your Stevens-Johnson syndrome. It's actually the most hepatotoxic drug. Even when we're reintroducing the drugs, pyrazinamide often is the last drug to reintroduce because it's the most hepatotoxic drug. Then the minor side effects are things like joint pain. And out of all the TB drugs, it's one that's going to be excreted by the kidneys. So it causes joint pain. It can reduce the excretion of uric acid, urate, and actually can precipitate hyperuricemic gout. It can cause itching, anorexia, nausea, and abdominal pain, but I will focus on the side effects a bit later towards the end of this lecture. Then in terms of ethambutol, which caused a bit of some controversy in terms of its effects on the vision, but now we've realized that the benefits actually outweigh the risks. And from the clinical trials that were done, the side effects that were related to vision were actually quite minimal compared to the benefits of you adding the ethambutol to the regimen in treatment of TB. It's actually one that is a bacteriostatic drug with a low potency. It inhibits the synthesis of arabinogalactin, which is a cell component of the mycobacterium. One of the major side effects is, of course, it causes optic neuritis. It can cause visual impairment because it may cause your optic retrobulbar neuritis that can cause color blindness, especially to green colors, and it can reduce your visual acuity and cause central scotomas, and it's much more common at doses of 25 milligrams per kg. There are no significant minor side effects that I've seen or come across. Now, in terms of treatment of TB, it's largely divided into two main phases. You have what is known as the intensive phase, where you're giving 4 of those drugs, the rifampicin, isoniazid, pyrazinamide, and ethambutol at a fixed dose. So we call this as the 4 fixed drug combination. And the whole purpose of this phase is actually for you to rapidly kill off all the mycobacterium that are multiplying, and you want to actually shorten the duration of infectiousness of this patient. Then you have the continuation phase, which limits the bacilli, and those that are still multiplying, it reduces the risk of treatment failure, the risk of relapse, and here we just give rifampicin and isoniazid. In the first phase, which is 2 months, regardless of whether it's the severe or non-severe form of TB, the intensive phase is a minimum of 2 months. Then the continuation phase is the one that varies depending on whether this is severe or non-severe form of TB. So here is a table giving you the different types of durations. So on this first part here, we have all those that are having non-severe forms of TB, including miliary TB. The only time when miliary TB is considered as a severe form is if it has meningeal involvement. But if it doesn't have meningeal involvement, we consider it as non-severe. So the intensive phase is going to be 2 months of rifampicin, isoniazid, pyrazinamide, and ethambutol, and 4 months of rifampicin and isoniazid. Then for the severe forms, that's TB meningitis, osteoarticular TB, and other forms of severe TB, like TB pericarditis, we treat them for 12 months. And remember, in these severe forms of TB, we want to add some corticosteroids to prevent further complications. So 2 months of rifampicin, isoniazid, pyrazinamide, and ethambutol, and 10 months of rifampicin and isoniazid. So in terms of the weight bands, remember that the tablets actually come in as a fixed combination. So they come in as rifampicin, isoniazid, pyrazinamide, and ethambutol. So they come in as a combination of rifampicin as 150 milligrams, isoniazid is 75 milligrams, pyrazinamide is 400 milligrams, and ethambutol is 275. Now, depending on the weight that is there of your particular patient, because remember that you want to weigh your patient before they start treatment, you want to weigh them during the treatment, before you now transition them from the intensive phase to the continuation phase, and even at times when you're reviewing your patients each and every month, get their weight, get their height, get their BMI. So you also have the 2 drugs that are combined, rifampicin and isoniazid, in a combination of 150 to 75. Now, depending on how much they weigh, if they're 25 to 37, 2 tablets. If they're 38 to 54, 3 tablets. If they're 55 to 70, 4 tablets. If they're greater than 71, you give them 5 tablets. Same thing in the continuation phase. So you can actually get a screenshot of this and keep it somewhere so that you can be reviewing your patients, and then when you review them, you'll be able to know how many tablets they should receive. Now, there is a role of corticosteroids, like I told you, and these are often given to those that have severe forms of TB, such as those that have meningitis, those with TB pericarditis, those with spinal TB, and this is aimed at reducing the long-term complications. And even those that have adrenal TB, sometimes they may become hypotensive, so you may actually put them on some sort of steroids. And remember, when you start your patients on steroids, the body is a very wonderful thing, because when you're giving it something that it is in excess, it will stop making its own. So when you give them a lot of steroids, the body stops making its own endogenous type of steroids. So if you stop these abruptly, there'll be a point where you don't have any steroids in the system. So which is why you want to taper off the steroids, and you should never stop them abruptly. So your steroids are going to be immunosuppressive. Remember that they block the immune system. And theoretically, this means that even in patients with HIV and TB, it puts them at risk of getting other opportunistic infections. But we have realized that the benefits greatly outweigh the risk, which is why we often put those patients that have severe forms of TB on corticosteroids. So you have some common indications for corticosteroid use such as TB meningitis, TB pericarditis, TB immune reconstitution inflammatory syndrome or TB iris. You have massive pleural effusions, massive lymphadenopathy with pressure effects, severe hypersensitivity reactions to anti-TB drugs. You have some rare indications like hypoadrenalism, those that have adrenal insufficiency, renal tract TB because you want to prevent ureteric scarring, and those that have TB laryngitis with life-threatening airway obstruction. Which drugs are you going to use? So if it's TB meningitis, prednisolone can be given or its equivalent, 1 to 2 milligrams per kg, a maximum of 60 milligrams for 2 weeks, then you taper it off over 6 weeks. Those that have TB pericarditis, 1 to 2 milligrams per kg with a maximum dose of 60 milligrams for 4 weeks, then you give them half, maximum dose of 30 milligrams for 4 weeks, then you taper it off over several weeks. Then for those with TB pleural effusion that is severe, those with TB iris, those with other forms of severe TB, 0.5 to 1 milligram per kg with a maximum of 30 milligrams for 1 to 2 weeks, then you taper off over several weeks. Now, what are some of the side effects of these first-line drugs? Remember I told you we can group them into 3. The minor, the major, and the life-threatening. Minor, you just simply have to reassure the patient and that the symptoms should be managed. And of course, TB treatment should continue. Major side effects, you should stop giving them any anti-TB medication, and then if you're at a lower facility, you refer them to a higher facility. Life-threatening, the same thing. Stop giving them the TB medication, refer them to the specialist or to a higher facility level. Remember that there are some age groups or people that are at risk of developing side effects. Those that have a history of using herbal medication, because remember, some of these TB drugs are hepatotoxic, and some of these herbal medications are hepatotoxic and nephrotoxic. You have those that take alcohol regularly. You have those that are taking other medications that could be potentially hepatotoxic, like fluconazole, nevirapine, protease inhibitors. Those with a history of peripheral neuropathy, those with diabetes, those with pregnancy and immediate postpartum period, those with malnutrition, like for example those that have low albumin, those with a low body mass index. Now, what are some of these side effects? So I've divided them into 2 main sections, the minor and the major. So we have anorexia, nausea, and abdominal pain, very common with pyrazinamide and rifampicin. Here we advise the patient to take the medication with. They should normally take it on an empty stomach, but they should take it with a very small meal. So maybe cook a bit of some porridge and they should take it with that, or the last thing at night. Joint pain is usually seen with pyrazinamide. We can give them some non-steroidal anti-inflammatory drugs like ASA, ibuprofen, diclofenac. Then, of course, you have burning sensation in the feet. That's peripheral neuropathy due to isoniazid. So we often give them 25 milligrams prophylaxis when they're on TB treatment of pyridoxine. If they develop peripheral neuropathy, we increase the dose to about 50 to 75. Sometimes you can even go as high as 200 milligrams a day. Then once the symptoms have actually resolved, we can revert them back to the 25 milligrams per day. Other treatments, if they're not responding, include things like pregabalin, carbamazepine, gabapentin, and even amitriptyline that can be used. You can have orange or red discoloration of the urine. This is seen with rifampicin, so we can actually reassure the patient that it's expected and they continue the drug. There could be some itching with isoniazid, pyrazinamide, and rifampicin. We can give them some antihistamines and emollients, and we continue to observe them. In terms of the major side effects, severe skin rashes, and even mucosal involvement, your Steven-Johnson syndrome, it's seen with isoniazid, pyrazinamide, and rifampicin. Here we want to stop the anti-TB drugs, and you reintroduce them in a specific way. We want to stop any other offending or potentially offending drugs that contain sulfur, like cotrimoxazole. You want to isolate your patients because they're at risk of having secondary infection because their skin is exposed and they are admitted in the ward. So you're going to start them also on prednisolone, 1 milligram per kg, add an antihistamine like a promethazine, keep the patient warm, give them adequate hydration using IV fluids, and then consider giving them some broad-spectrum antibiotics to prevent any secondary infections. You can have those that have shock, purpura, acute renal failure, and thrombocytopenia, very commonly seen with rifampicin, but very rare thing to see, especially with the shock. You must rule out other causes of shock. So you stop the TB treatment, manage the shock as appropriately as possible, refer them to the next higher level facility if you're not at a high level facility. For those that have jaundice or hepatitis, it's seen with isoniazid, pyrazinamide, and ethambutol, and remember that pyrazinamide is the most hepatotoxic. So we stop the drug if we see that the jaundice is severe or it's worsening, they're developing hepatic encephalopathy, their INR is raised, remember the normal is less than 1.1, and their ALT is raised. If it's greater than 5 times the normal and they're asymptomatic, you stop the drugs. If it's greater than 3 times the upper limit of normal and they are symptomatic, then we stop the drugs. They could have also psychosis and convulsions seen with isoniazid. We stop the treatment, refer them for a psychiatric evaluation. And then for the visual impairment, it's often attributed to ethambutol, which you should stop and refer them to an ophthalmologist. Now, how do we manage TB in special considerations? I'll talk about TB with HIV briefly, but I'll dedicate a video on its own to discuss TB and HIV. I'll also talk about TB in pregnancy, but there'll be a separate video for that. And then you have TB with kidney disease and TB with liver disease. So remember that all patients that are co-infected with TB and HIV, you want to treat the TB first, because TB will potentially kill your patients. HIV will not kill your patients. So you want to start all your patients that have TB on treatment regardless of the CD4 count. Remember, you want to start off by giving them the TB medication first, because you want to prevent the IRIS from happening, immune reconstitution syndrome. So you give them the TB treatment until they're well tolerated, which is roughly about 2 weeks. Then you can initiate the antiretroviral treatment. Remember that those patients that have HIV infection are going to be profoundly immunosuppressed. They should receive the ART within the first 2 weeks of instituting the TB treatment. Then, of course, you must be looking out for IRIS, and you should be able to identify IRIS. If you see it, then you start them on some steroids, but you still continue the medication. There is some modification that needs to happen in terms of the ARV regimen. You should avoid drugs that have overlapping side effects, and there are some important drug-to-drug interactions that I talked about when I looked at my HIV series, and then also I will talk about in another video discussing about TB and HIV co-infection. One important one that I want you to remember is in terms of rifampicin and integrase inhibitors. Remember that there is some sort of interaction that is there. The rifampicin actually lowers the effective concentration of integrase inhibitors in the bloodstream, such that if a patient is on dolutegravir and you found them with TB and you've started on a rifampicin regimen, it means that you're going to double the dose of dolutegravir. So you're going to be giving it twice a day, or 50 milligrams twice a day. Then there is also interaction with other drugs like non-nucleoside reverse transcriptase inhibitors and protease inhibitors. Remember that co-infected patients have a risk of drug toxicity and TB reconstitution inflammatory syndrome. Then in terms of TB and pregnancy, remember all the TB drugs are safe for pregnancy. They should be started. Once you find a woman that's pregnant with TB, start them on TB treatment. And once the woman that becomes pregnant during the treatment, they should continue the TB treatment if they were on TB treatment. And remember that women that are on TB treatment and intend to get pregnant and have a child, they should first consult their doctor or their clinician before they decide to get pregnant. And remember that rifampicin, I've already talked about this, will lower the effective concentration of hormonal contraceptives. So it means that you must use alternative methods like condoms. Then in terms of breastfeeding, those that have TB, you advise them to continue breastfeeding, but there are some special things that they must do. If they are smear positive, then they should spend less time with the child, because that child is at risk of getting the TB infection. When they spend time with the child, especially with breastfeeding, it must be done in a well-ventilated area with sunlight that is entering into the room. They should wear a mask when they're breastfeeding as much as possible. And these children that are born to mothers that have TB should be vaccinated with BCG at birth. We should give them some TB preventive therapy, which we'll talk about in another video. And they should give this if the child is well and they have no signs of TB. Congenital TB, we'll talk about that as well. Then after completion of this prophylactic treatment, then this child should be revaccinated if they don't have a BCG scar. Then if the mother develops TB during breastfeeding, you should give the child the TB preventive therapy if they are screened negative for TB. We revaccinate the child if they don't have a scar. Remember that those children that are HIV exposed or HIV positive should be given BCG at birth and when active TB has been excluded, because you don't want to give them the vaccine if they already have active TB. You want to treat them for the active TB. Then you should start them on the TB preventive therapy. At the end of the preventive therapy, you should actually revaccinate the child if they don't have a scar. Then in terms of kidney disease, remember rifampicin and isoniazid are excreted by biliary excretion, so they don't need any renal adjustment. But pyrazinamide and ethambutol, together with some of their metabolites, are going to be excreted by the kidneys, so they need some sort of adjustment. So we give half the dose of ethambutol daily, and pyrazinamide should be adjusted based on the creatinine clearance. For those that have a creatinine clearance less than 30 mils per minute, pyrazinamide at 25 milligrams per kg, and ethambutol at 50 milligrams per kg can be given. And remember, while receiving isoniazid, your patients with severe renal insufficiency or renal failure should be given pyridoxine to prevent peripheral neuropathy. Then in terms of liver disease, I'll spend a bit of some time here. Remember that potentially the three drugs, rifampicin, isoniazid, as well as pyrazinamide, are potentially hepatotoxic, with pyrazinamide being the most hepatotoxic drug. And most of these are going to be causing liver injury, and so should be given with caution, especially those that are alcoholics, those with underlying liver disease. Rifampicin and isoniazid plus one or two of the non-hepatotoxic drugs, being streptomycin or ethambutol, can be used for a total of about 6 months or 12 months, depending on the regimen that you're using. If your patient has severe liver damage, evidenced by greater than 2 times rise in the ALT, the upper limit of normal, if they are symptomatic, or 3 times greater than the upper limit of normal if they are asymptomatic, then an alternative regimen with streptomycin plus isoniazid, rifampicin, and ethambutol can be used in the initial phase, followed by either rifampicin and isoniazid for months, or for 4 months, or isoniazid and ethambutol in the continuous phase for a total of 12 months. So you have streptomycin, isoniazid, and ethambutol in the intensive phase. Then we give them ethambutol and isoniazid in the continuation phase. So 2 months of streptomycin, rifampicin, isoniazid, and ethambutol plus 4 months of rifampicin and isoniazid, or 2 months of streptomycin, ethambutol, and isoniazid plus 10 months of ethambutol and isoniazid. Now, there are many reasons why someone could develop drug-induced liver injury, what we call DILI. One, remember the 3 drugs that you're giving are potentially hepatotoxic, with pyrazinamide being the most hepatotoxic. Even some of their metabolites are hepatotoxic, like in the case of pyrazinamide. Systemic inflammation, it can also induce immune response in the liver. There are some nutritional status, which is low levels of serum albumin. Some patients could have co-infection with hepatitis B and hepatitis B iris. You could have someone previously or currently taking alcohol. There are other drugs that could be given that are hepatotoxic. HIV medication, cotrimoxazole, fluconazole, alternative regimens. Someone could have hepatic TB or TB iris. All these things are contributing to drug injury. So once you evidence that your patient has worsening jaundice, increasing liver enzymes, you stop the TB medication. And you only want to reinstitute them if the following criteria are met. Number 1, there should be no alcohol abuse currently. Number 2, the patient mustn't have any hepatic encephalopathy. If you're not able to get your ALT and your bilirubin, the jaundice must have subsided. And of course, your ALT must be less than 100, less than 2 times the upper limit of normal, and the bilirubin must be normal. So for your patients that develops drug-induced hepatitis, you want to monitor the ALT weekly for a month. If it remains normal after a month, then you can have close monitoring and repeat whenever clinically necessary. Or you can monitor them clinically for the jaundice and its recurrence each and every week. Now, there are 2 options into how we actually introduce the drugs. So there's one option 1, where you're going to give them all 4 drugs at once, but then you increase the number of tablets that you're giving. For example, on day 1, you give like 1 tablet. On day 2, you give 2 tablets. Then on day 3, you can give them the full course, maybe 4 tablets, for example. And this one is recommended for those patients that have low risk of hepatic injury. And then there's option 2, where you introduce the drugs separately, with the least hepatotoxic going to the most hepatotoxic, either starting with isoniazid or rifampicin at a low dose. Then you increase to maximum dose, you introduce a second drug at low dose, increase it to maximum dose, then you add your third drug at low dose, increase to maximum dose, then you add the last hepatotoxic drug, which is ethambutol, as you continuously monitor your liver enzymes. This one is done for those that are at high risk of hepatic injury. So here are the 2 options. Here is option 1. So we start off with on day 1 with 1 tablet. You're checking your ALT and your AST. Day 2 with 2 tablets. Day 3, you're doing your full dose. At day 3, you also check your ALT and AST, so you do it on alternate days. On day 4, full tablets or full course, whether it's 3 tablets or 4 tablets or 5 tablets. Then day 5, also full course. You repeat your ALT and AST at day 5. Remember that after day 5, you're going to be doing the testing weekly for 1 month. Then afterwards, you do it twice weekly, every 2 weeks for the next 1 month. Then you can do it every 3 months afterwards if their enzymes have normalized. Then option 2 is now introducing them a single drug, either starting off with isoniazid or you can start off with rifampicin. So day 1 to day 3, you give them ethambutol rather, full dose, plus isoniazid 50 milligrams, which is like a low dose. You do your ALT and AST at day 0 and day 3. Take note, if the liver enzymes begin to rise, you don't continue, you don't add the drug. Then at day 4 to day 7, you are now having isoniazid increasing to 300 milligrams, you're also checking your ALT and AST. You'll be doing them every 3 days. Then from day 7 to day 9, we have ethambutol, isoniazid at the dose that it's supposed to be given, and we add rifampicin at 75 milligrams. Then you're checking again your ALT and AST at day 9. Day 10 to day 12, we increase your rifampicin now to 300 milligrams. This should be milligrams, not nanograms. And you're checking your ALT and AST at day 12. At day 13 and day 15, you give them the normal dose of rifampicin, isoniazid, ethambutol, plus pyrazinamide. You start off at 15 milligrams per kg. You check your ALT and AST at day 15. Then day 16, we increase now the dose to the maximum dose of pyrazinamide at 30 to 40 milligrams per kg. Then we should review our LFTs, our liver function tests, every week for the first month, then every 2 weeks for the next month, then we do it every 3 months, just like with option 1. So what about monitoring TB patients and following them up? Remember, you must see your patients at least once. If they're sick, you're going to be seeing them a bit more frequently. But in periods where you have outbreaks, like the time when we have COVID-19, we didn't want our patients to be coming quite frequently because you're putting them at risk. You're also putting yourself at risk of infection. So at every visit, you're going to do a clinical review. You're going to assess for side effects. You're going to do dose adjustment based on the weight. And of course, you're going to offer some adherence counseling, and you continue the counseling of these patients. Record all your TB patients that are found to be having TB on your TB registers at your facility, and ensure everyone that is diagnosed is entered into these registers. Whether they died, whether they are lost to follow-up, before they even start treatment, enter them into this register. Issue your patients with a TB card that you must be following up periodically and updating. So there is a program that's known as the DOTS, or a strategy that's known as DOTS, Directly Observed Therapy and Surveillance, which helps actually improve compliance of the patients and helps with them taking the medication in an attempt to also reduce occurrence of resistance. So there are 3 plans that can be done. Remember that this is just simply an observer that is accepted by the patient as well as by the healthcare system that allows the patient to be observed taking the medication each and every single day and records it somewhere. So there are 3 plans. You have DOTS Plan C, which is the clinic, where the TB patient goes to the clinic and they are observed by a nurse or a healthcare worker that is trained swallowing the tablets. Make sure that you check even under the tongue, because sometimes we'll just put it under the tongue and say they have swallowed it. Then the DOTS Plan V is for the volunteer. So this is a person in the community, a volunteer. Maybe it could be a community worker, it could be at the workplace, it could be at the school. They are observed swallowing the medication. And then DOTS Plan R, which is the relative, which is most patients actually tend to opt for this. It's going to be a relative that is monitoring the treatment of this patient. Remember that this is required for those that you think are highly unlikely to comply, those with history of serious mental illnesses, those with history of non-adherence to therapy in the past or during the current treatment course, those that are living in the street or shelter dwellers that are homeless, those that have multi-drug resistant TB. How do we monitor our patients? So remember that for those that have DOTS Plan R and V, we review the ID card when the patient comes into the health facility. Your treatment supporters must write their initials on the card on the days when they observe the patient taking the drugs, and if they didn't observe the patient taking the drug, you put a 0 on that particular day. Then you update the treatment card using the information on the patient's ID card. You should mark an X on the horizontal line on the days when they took the medication and they were observed taking the medication, and a 0 on the days where they did not take the medication. And then on the treatment card, enter an X on the day of supply after observing that the day's dose was taken. We often draw a horizontal line in the same card through the number of days which you're going to be supplying them with drugs. Then in terms of those that have bacteriologically confirmed TB, we monitor them using sputum. So we should actually do a sputum examination at 2 months, 5 months, and 6 months. So it's actually important because you want to determine the response to treatment and make a decision on this patient's care. So remember that the best indicator that this treatment is working is that they must be smear negative. They must seroconvert from them being smear positive to them being smear negative. Then you know that they were taking the medication regularly and it was quite effective. In the cases where they have this poor bacteriologically response of treatment, then you should make sure you exclude drug resistance. I'll do a different video on investigations that will include investigating for drug resistance. So we should set our samples for culture and drug susceptibility testing. Remember that GeneXpert MTB RIF should not be used for follow-up, except in those cases where we presume that there's drug-resistant TB. We should instead use smear microscopy for follow-up. So follow-up of bacteriologically confirmed TB, use microscopy. Because if you do the GenExpert will give you a positive result even with the patient on treatment. Then for the bacteriologically confirmed TB, remember you're doing your smears at 2, 5, 6 months. And each time they come for the monthly visits, you review them for the side effects. So if at 2 months the smear comes out positive, you send samples for GenExpert MTB RIF to check for rifampicin resistance. You send them for culture and the first-line drug sensitivity testing. You provide them with intensive adherence counseling. You do a full clinical evaluation, and you extend your intensive phase by 1 month. Then if it was positive at 2 months, you repeat the smear at 3 months. If it wasn't positive at 2 months, there's no need to repeat the smear at 3 months. The next time you're going to repeat the smear is at 5 months. You continue the treatment and manage them depending on the results. And remember that the results should be available at the visits and should be recorded in your patient's card and in the register. So here's a summary. So you're going to be doing smears at 2, 5, and 6 or 12 months, regardless of the previous results. The patient must have at least 3 smears done for those that have bacteriologically confirmed TB. If it's positive at 2 months, you send the sample for GenExpert MTB RIF, your culture drug sensitivity testing, provide intensive counseling, do a clinical examination, and extensive intensive phase treatment. You extend it for 1 month. Then at the 3rd month, if it's positive, then of course you repeat the smear. If it was positive at the 2nd month, you repeat it at the 3rd month. If again the smear is positive, it means that you should send your samples for culture and drug sensitivity testing. Ensure that the samples actually arrived at the laboratory. If the smear was negative at 2 months, no need to repeat the smear at 3 months. At 5 months, you repeat the smear. If the smear is still positive by 5 months, then you declare that this patient has treatment failure. Then you investigate them or you do your drug sensitivity testing and you review the results. Then at 6 months and at 12 months, if the smear is negative, then you assign the appropriate treatment outcome, whether they are cured or the treatment has just been completed or treatment has failed. Then of course you should send, for those that have smear positive at 6 months or 12 months, send them for GenExpert MTB RIF to check for rifampicin resistance, culture, as well as drug sensitivity testing. Then for those that have TB that was clinically diagnosed, that was not bacteriologically confirmed, you want to assess them and review them because they don't have any sputum, but they have some symptoms of TB. So you want to follow them up. And sometimes sputum examination may not be so feasible, but if they can provide sputum, after 2 months, they should provide some sputum. Assess the clinical status. The symptoms should have started to disappear or should have disappeared. Then, of course, they should have started gaining weight, and these are some of the things that you're looking out for. So the other lectures that I want you to look out for are a lecture on TB basics. We'll do an in-depth review of TB investigations, including drug sensitivity testing. We'll do a lecture on TB and HIV, TB and COVID-19, management of TB in children, management of drug-resistant TB. Will also include the 2nd-line treatment regimens, the drugs that we're going to be using, and then, of course, lastly, we'll look at TB infection prevention. So, like I said, this is a lecture that you cannot do in one particular setting. This is only but one of many videos that we'll do over the course of this week and the next. I really hope you enjoyed this lecture on TB management in adult. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.